Great, so I think we'll go ahead and get started, and hopefully a few more people will be joining us. So good morning, good afternoon, good evening from wherever you're joining us from. A warm welcome on behalf of the Boost team to our Bright Spots webinar featuring the story Influencing Immunization Beliefs, Who Holds the Key? Before we get started, I just want to go over a few housekeeping slides. Next slide. So we're using a Zoom meeting format today, so we ask that you remain muted to minimize any background noise. You can always raise your hand during the presentation to speak or to use the chat box to submit questions, make a comment or respond to other participants on the call. Again, now would be a great time to introduce yourselves, tell us your name and where you're joining us from in the chat box. Next slide. So for those who are joining us for the first time, the Boost community is a diverse network of more than 1,500 immunization professionals from over 125 countries. Through our online platform, boostcommunity.org, we offer opportunities for our community to connect with peers, strengthen leadership and advocacy skills, and grow in their careers. And just a quick note that we will be storing today's session recording and slides in the resource library of the Boost Bright Spots Learning Group. So I encourage you all to join the group on the platform. Next slide. And for those who are joining that are new to this particular series on Bright Spots are stories that shine a light on the work that is happening on the ground and inspire immunization professionals everywhere to learn, adapt, and take action in their own communities. From engaging with religious leaders in the community to improving supply chain delivery to reach the last mile, there's really innovation happening at all levels of the system. This second round of Bright Spots, which was announced earlier this week, includes 10 stories from 6 countries. Over the next few months, we'll be slowly releasing these stories on the Bright Spots Biker site, which is brightspots.boostcommunity.org, I think which we'll share out in the chat box. So definitely stay tuned. We'll also be sending some e-blast out whenever we release a new set of stories. And through this live series, we're offering the opportunity for our members to hear directly from Bright Spots story submitters to better understand their challenge or program and how they achieve success. So with that, I'd like to introduce our speaker for this session, Dr. Attahir Abubakar. So Attahir is a technical assistant for the state and local government area emergency routine immunization coordinator centers. Ooh, mouthful. Not only has Attahir been busy in this position, but he's also been a very active member of the Boost community, joining several of our courses and also positively contributing to peer conversations on the platform. We greatly appreciate Attahir's engagement and are excited to feature him and his work today. So with that, I'd like to pass over the mic to Attahir.
Good afternoon, good evening, good morning, depending where you are. As Liz said, I'm Attahir Abubakar from Nigeria, supporting the Emergency Routine Immunization Coordination Center. The problem I'm going to discuss started after the LeaksMix survey in 2016 that shows routine immunization uptake in most of northern states very optimal, very poor. In some of the states, Penta 3 coverage is just 9%, 6%, which prompted the National Primary Healthcare Development Agency to quickly form an emergency situation called the National Emergency Routine Immunization Coordination Center at the headquarters in Abuja, while states and LGA were mandated to form State Emergency Routine Immunization Coordination Center and local government local immunization coordination center, the SERICC, and LERI. That's how the framework looks in order to support the immunization uptake using an emergency strategy. Next slide. Yeah. Nigeria is a deeply religious country. We know both Christian and Muslim are deeply adherent to their religions. And the faiths, across the faiths, adherents rely deeply on the direction of their religious leaders. Religious leaders in northern Nigeria have upper hand over every person because anything they say, most of their followers don't ask second question, they do it. They abide by their religious leaders. So government directive at times, if a government wants to implement some activity or some programs, they need to follow through the religious leaders. So religious leaders, the imam and pastor, play a vital role in Nigeria. Next slide, please. What we try to accomplish, or our mission, we want to use the community ulamas and Ugwa to connect to the people. Secondly, we want to learn from other intervention, what have been done in other places, what has been done to achieve. And lastly, we want to lead by example. If I'm preaching A, B, I expect you to do A, B. So what we try to teach the religious leaders, if you are preaching immunization, we want to see you bring in your family to be immunized at the nearby PACs openly, so that every person will see that after being preaching immunization in your sermon at your religious house, you also practice it by bringing your family to be immunized. Next slide. Yeah. Religious clerics promote routine immunization and other health services by delivering messages to husbands, fathers, and sons at mosques. Mostly, the Friday before a Friday prayer or an Eid prayer, the Imam stand up in front of his followers and preach and pass a sermon in which some messages are being passed. So during that kind of sermons, immunization and other healthcare services messages are being passed on to the communities. Mostly the husband, the fathers, and sons are at the box, who later transmit that information back to their families at home. Mostly in northern Nigeria, the husband is key. It's mostly it's the husband that will permit his wife to go out. If the husband say no, you are not going out, you have no right to go out. So husbands are pivotal in health seeking behavior of his family. Next slide. What is our challenges? What we realize is most of those ulamas or clerics, they lack knowledge of childhood vaccination. They don't know what is childhood vaccination is. Why are we immunizing the children? Then there's misconception. A lot of people have misconception on immunization. Some will say it's a plot to reduce births. Some will say it's for this reason. There's a lot of misconception about immunization. So those are the challenges that most of our clerics faces. While some religious leaders had advocated against vaccination, they label it as anti-faith. They want to reduce the population of Muslims. In particular, for example, some Muslim clerics will say they want to use that vaccination so that your woman will not be giving birth and you will have lower birth rate, so your population will go down. This position was accelerated by prevailing myths around the use of vaccine as a Western tool for population control. So what we try to inform them, if the West want to control their population, don't you eat other things produced in the West? For example, there is this spices we call Maggi. None is being produced in Nigeria. This soda drinks, none is being produced in Nigeria. All the companies are Western company. So they can't control their population via that. It's only through immunization that can provide good health for your children. Next slide. Who are the most significant contributors to the result of this program? We have the religious leaders, who are the gatekeepers in all our communities. The Council of Ulamas, who are the leaders in all of their religious places. The healthcare providers at the facility, they play a role. The journalists, they play a role. Entertainment people who uses music, video, audiovisual to pass on information. Then the Minister of Religious Affairs, who normally organizes a weekly sermon in the state capitals. A weekly sermon is being organized in the state capital so that the information can be passed. Then security personnel. In some of the areas, we have high security challenges. So we have to use security personnel in those areas because they supported us. There are some polio survivors who have that experience. So they too have played a significant role in contributing to the result of this program. Next slide. Most of the areas of discussion rally around religious and traditional leaders. The concept of immunization for basic of Islamic faith, such as we highlight that any Muslim that is going to Hajj in the Kingdom of Saudi Arabia, the first thing they will do after landing at Jeddah International Airport, 2 drops of polio will be given to you, especially people from Nigeria, Pakistan, Afghanistan at that period, before Nigeria was certified polio free. But last year's, any person from this country going to Saudi Arabia must be vaccinated with polio. Then we look at the principle of quarantine in Islamic perspective. In Islam, anybody that is traveling to a country, any place, if there is plague or epidemic in this country, the Prophet of Islam said you shouldn't go to that area, stay in your area, in order not to go and catch that disease. So that means there's a quarantine in Islam. Then another aspect that we try to bring, none of us used to see calamities in life, but after prayers, we raise our hands up, oh God, protect us from A, B, C, D that we are afraid of. That too is also prevention, is preventive. You are trying to find a way of God to protect you from being infected with something that you are afraid of. So we try to bring those areas into discussion with the ulamas. Most of these ulamas are located within the communities. They reside in the community, they attend the same market, the same mosque, the same function, the same naming ceremony. In northern Nigeria, mostly after a child is being given birth, that's what we call a local Ogozoma, a traditional birth attender, who mostly attend to that woman. Then we have the local baba who will come after 7 days to bath the child. Then we have the a local imam who will come and name that child after 7 days. All those people are key. Then we have the chief slaughter who will slaughter the ram for the child. So all those people are very critical community resource people that we use to pass information on immunization too. Next slide. Excellent. Our challenges: religious, sociocultural, and safety concern. People are looking at religion does not give room for immunization. Some cultural background is saying immunization is a taboo, while others are looking at safety concern. Like what's happened in Kano some times back during a measles vaccination by Pfizer, a lot of people, a lot of children were infected. Some die, some cripples, a lot of abnormalities happens during that period. So it affected uptake of immunization. So that's safety concern. Then another concern that people are talking about on immunization is childbirth, because it's a misconception, seriously, you know it. Then most people that are doing this or saying this, they lack knowledge about childhood vaccination. When you ask those kind of people, what do you know or understand by childhood vaccination, he will tell you polio. All he knows is polio. He doesn't know that there's other vaccines that a child needs to be given. Then there's violence against vaccinators at the community level. We all know that during campaigns, most of our health workers that goes house to house are being attacked. In Kano, Maiduguri, and Yobe, a lot of vaccinators have been attacked, kidnapped, maimed, and killed. So it's very difficult to get somebody to move at times. Then this misconception of vaccination, concept of what is vaccination. I could remember when I asked some person, what did you understand by vaccination or giving a child immunization? He say it's polio. That polio is what you people are after. Then I asked him, there is this thing we call measles in local language because it's the Congolo in some northwest or Bakondoro, which affect child. So I try to, okay, did you know those diseases that can be preventable using vaccination? He said, no, he doesn't know that. So we try to explain to him that, okay, a child needs to have vaccine A, B, C, D to prevent him from disease A, B, C, D. How did we arrive to this result. First of all, we map our allies at the community level. Who are our allies? Who are in favor of immunization? Then we look at those that are at the neutral level. Then we have some passive opposition ulamas that we know with constant engagement, discussion, one-on-one, we can change their stand. Then sensitization sermon by religious leaders during Friday mocks, which has become a key critical thing and a turning point in some of the community. Because the moment an imam stand on his pulpit after during the sermon and mention immunization, then that child, that sermon will ring a bell in most of our parents, either father, either mother or grandfather at that box. So they help in shaping or fine-tuning the thinking of other vaccine hesitant people in most of our community. Next slide. This is one of a view of a person after engagement for like 4 months. I used to chase off immunization officers whatever they come to I do, because I believe there were hidden agenda behind it. And I was also uncomfortable allowing my wife to go to the hospital. His view changed when ulamas began to explain to the community the importance of allowing women and children for immunization. Next slide. This quote by Albert Einstein. Okay. Next slide, please. What we learned during this short proactivity or short intervention that we did, using innovative engagement and coalition campaign at the community level is key in resolving vaccine hesitancy. You don't bring people from outside. You use people from that community, people that are residing with the people, with those hesitant people. But the moment you start bringing people from outside, some will read it into it. Then engaging traditional religious leaders to mobilize caregivers against social norms that prevent families from vaccinating their children is key. You have to work with those gatekeepers. Traditional leaders are the gatekeepers of our costume. So working along with them has helped us in reducing some of the misconception about vaccination of children. Then our turning point, delivering the life-saving message during sermon has helped a lot. It has helped a lot because people are, so this imam now has accepted immunization. At the beginning, there are some hesitant people, but later on, when it becomes frequent, it changes. It's a turning point for a lot of people. Next slide. A takeaway. We have to equip our leaders, both traditional and religious leaders, with knowledge of childhood vaccination, because most of them doesn't know what is childhood vaccination. All they know is polio. When the people call them for a meeting at the LGA level or at the state level, is polio discussion. So it has affected them seriously. So when if they are being equipped with childhood vaccination knowledge, with their leadership skills, they can be able to transmit and change a lot of things in their community. Next slide. For my advice for immunization professional with similar barriers, first of all, study the situation and map your allies. You just don't go directly to the community and start doing things. No, you have to map your allies. Who are your allies? Who do you think you will start with? Who do you think you will leave it after engaging A, B before I engage C, D? They engage community resource groups, the VCM, traditional barbers, and others. They are key because they go house to house during the ceremony. that VCM has a lot of influence in the community, because in most of our community, they call them doctors. So if you refuse immunization, when you call her, most of the time she will refuse calling to support you. Then traditional leaders constitute an on-tap resources in the community to boost routine immunization, and a key link needed to bring various stakeholders on the same path to better health engagement. Thank you. Thank you. Next slide. Okay, this is our, before implementation, this is where our fixation was. Our fixation is some of our facilities that we monitor. But after we started in March, this started from March 2020 to December 2020. Next slide. This is our outreach session. Next slide. This is our pediatric coverage. No, all these are administrative data, not survey data. Data were filtered from DHIS. Next slide. Thank you very much.
Great.
Question.
Thank you so much, Attahir. So for all the participants who are joining us today, we would like to open it up to questions. If you have any comments that you would like to share with Attahir today. Oh, I see a hand raised. Ismalia, I will ask you to unmute. Would love to hear your question.
Good afternoon from my side. Hello, can you hear me?
Yes, we can hear you.
Hello?
Yes, we can hear you.
Yes, this is Ismaila Ibrahim Edego, independent immunization consultant from Zaria, Nigeria. I want to first of all congratulate Attahir for that wonderful presentation. It was a nice presentation. Mine is not a question, actually, I want to add something. In the course of the presentation, Attahir made a point that in the north, the women have to take permission from the husbands before going for immunization activities. Yes, that is true. And I want it to be on record because people have different perceptions regarding gender consideration when it comes to immunization. They said in northern Nigeria, you see women participating more in immunization activities. That is true. But in doing so, they need to seek permission from their husbands. And their husbands have to give them that permission before they will go out. In that case, it means both the men and women are involved because mostly the men are in their offices and workplace. So in the future, we need to always understand that in the culture of the northern people in Nigeria especially, men are involved in vaccination because they give that permission for women to do so. So thank you. Let me give others the opportunity to talk. I have a lot to say, but let me be very, very considerate. Thank you. Over from my side.
Thank you, Ismala. Attahir, did you have anything to add before I?
Yeah. I had
Sure.
something to add.
Sure.
I think I did a research on male involvement in immunization, which I am yet to publish. Male has, as he said, male has a lot of influence on immunization. Not only giving permission, some will even give transport to their spouse for immunization.
That is very
because
true.
because of the nature of men's jobs. Most of the men will leave early in the morning. Someone will not come back until around late in the night. So he doesn't know what is happening in the house. So when going on in the morning, some will drop money. Okay, I'm going to hospital, Oga, or we're going to hospital today. Okay, this is the money for A, B, C, D. Then he will leave. While some are supportive. I know of a man that he carry his wife to the facility for immunization.
That is also very true.
Great.
Thank you, Ismail.
Great. Well, I see a few more hands raised, but I do want to encourage anyone who has questions to type them in the chat as well. But with that, I will ask Rajat to unmute if you have a question.
Yeah, thank you. Firstly, I would like to congratulate for the excellent presentation. I think the infographics and the presentation and as well as whatever Attahir talked about, it was great and it was a great learning experience for me as well. I could relate to many of the activities in India which happened during the polio campaigns and also during the routine immunization. I have just two questions to ask. Firstly, there is one issue that I have seen during the measles rubella vaccination campaign and also the routine immunization campaign is that usually religious leaders also have their different organizations, and maybe their organizations they a set of people like one part of the village may be listening to one leader and the other part of the village is listening to the other leader. So if we are going with the communication activities like with the appeal or something to one part of the village, so to the whole part of village, people may not be willing because some people will be left out. They are not listening to that religious leader, that particular religious leader. They are listening to the camp leader from the another camp. So this is what I have observed in India, and so we had to do the micro planning and we have to identify in the communication plan which leader should actually should which leader should be used in which area, and how we should be using the appeals. And my second question is that many a times I have seen in especially in Muslim community, or maybe you can say in a deprived community, that what happens is that uh, um, usually the decision of the vaccination, it relies on the father. So father is the decision maker and he is outside of the house whenever the vaccinator is visiting at the daytime. So the mothers are not able to take the decision. So I just want some insights from Attahir, if he can share his insights about these 2 points. Thank you.
Okay. Thank you, Rajat. In most of, if I understand your question, in most of our communities, religious leaders and traditional leaders have demarcation. You can't leave town A to B. They won't listen to you. Most of the time, they will not listen to you. So normally what we do when we started, we mapped our religious leaders based on their communities of residents. So we engage them. So they have more influence in their community. Then later, we even organize like inter-community discussion dialogue so that community A will look at what community B is doing to address their challenges. So share knowledge sharing. So it also helps us. So that's what we did. Sorry, a second question. Can you reframe it? I couldn't pick it. My
Yeah,
light
yeah.
was breaking.
Thank you for answering the first question. And the second question was that many times I have seen that the decision maker, who is a male, is outside for work, and the mothers who are there when the health worker is visiting the house, then she is not able to take the decision because the male is the male person is the decision maker and he is outside. So I believe that such situation must be arising and in your part of the world also. So what is done to address that?
Okay, yeah, we have similar things as you said. Male are the decision makers, and most of the time they are not in house. So mostly what we try to do now, in what we did, we try to make them male caregivers to leave a message at home. Even if my absence, if a child is sick, you can take him to a hospital. But for immunization, mostly you ask the husband in the morning, or if the husband is the one the kind that travel out, because in our society, during the dry season from November, December, January, most of the men travel to the cities to look for fortunes. So what they will try to advise them is try to seek the consent of your husband, even through phone. If he doesn't have phone, maybe his friend has phone. So you can ask him that a child is due for immunization also so did. And after 4 weeks, I'm going to return him. So most of the husband consent on that idea and agree to release their wife for the immunization. Maybe able to answer you briefly. Say that
Yeah, thank you.
if generally seeking advance consent. We try to make the husbands give an advance consent for health seeking. If a child is sick, even in my absence, you can go. So we try to marry that with immunization too. Thank you.
Great.
Thank you for that.
Excuse me, is it good for me to add something to what Attahir has given?
I believe we have a few more questions, but I'm happy to circle back. I just want to make sure to give everyone an opportunity to ask their questions. With that, I'll pass it. Danjuma, did you want to unmute and ask your question to Attahir?
Hello?
Hi, we can hear you. Yes.
Yes. Yes, I'm Danjuma Udoji Makoshi. I'm the WHO State Technical Officer, in which I work with Attahir at Zamfara State. That was 2020 last year. And it was quite very interesting to let you know all what Dr. Attahir is trying to portray in the presentations were true, because I was there in person. And for the time I spent in Zamfara, I barely go out for supervision. Why? Because of insecurity. The WHO did not give me clearance because of my safety. So I always work from office and do go to the metropolitan settlement. So it means that Zamfara have a lot of issue to deal with concerning immunization for the time I spent at Zamfara State. And I work hand in hand with the program manager, SERICC, and also Attahir. We implement the measles second dose in Zamfara State last year. And what I was able to impact in the state was on the issue of their vaccine utilization. But from the presentation, he made mention of people, foreign, they tend to neglect, or they are not giving room for foreigners or people coming from outside, and in which I experienced that. But as from the time I left, I don't know if Attahir, if there is any way the SERICC, the PM SERICC, or the state management on health, they are working in order to see that people coming from outside are being incorporated into the system, to see that they make their own contribution. What is happening as of now, since we are able to indicate it as a problem?
Thank you very much, Danjuma. This problem you mentioned still exists. It's something that not going. It's something that will be wise, but not easily.
I know.
Yeah. So as of now, what we are trying to look at some true angles in this problem, trying to make people understand. Even you don't know this person, he's coming with a person that you know. So and that person that you know will not cheat you. So accept you with an open hand. You know, it's easier to develop a habit, but for you to diffuse that habit, it will take time. But like in some LGS, I can mention some LGS that this thing has started reducing drastically because of the cosmopolitan nature of those LGS, like Auranda, Shinkafi, Gusau Town, Talata Mafara. Those LGS, they have diffused a little bit such kind of attitude because it's a cosmopolitan LGS where the educational level is a little bit higher than those conservative LGS. Most of those conservative LGS, the education level is very low or poor compared to those cosmopolitan LGS, like Bukuyum, which is a conservative LGA, Birnin Magaji, Zurbi, they're all conservative LGAs. So the education level there is not to a standard or a little bit improve. But what we are trying to do, we are working with NOAA, National Orientation Agency, to sensitize people on this kind of aspect. Until next time when you come, you will see change. Thank you.
Great, thank you. With that, I'll pass it to Bertha. Did you have a question you wanted to ask back here?
All right.
Okay. My PM SERICC is in the room. Can he talk, please?
Yeah, Bertha, could you unmute yourself, please, and ask your question?
Almustpha.
Hello.
Oh, hi, we can hear you.
Okay, thank you so much. The presenter, it was wonderful. Actually, I'm called Natango Bertha from Uganda. Presentation was wonderful. Actually, political leaders and religious leaders greatly affected immunization coverage. I would want to know from the presenter how in Uganda we have village health team, people who go around the community trying to sensitize the community, wondering if they have used that measure or that strategy before, and also if other factors like distance from facilities, stockouts, how they've affected, and generally, how has COVID-19 affected their strategies that they are currently in place? Like, for example, okay, this side we have lockdown, I don't know about Nigeria. So how has that affected the immunization coverage? Thank you so much.
Okay, thank you for your question. For this question, I'll allow my PM to answer it because we are together in this business. Almustpha, over to you. Almustpha. Okay.
Hello, good afternoon, ladies and gentlemen. Apologies for joining the meeting late. My name is Almustpha Alinkilofeature. I am the program manager, Zamfara State Emergency Routine Immunization Coordination Center program. Thank you very much, Dr. Attahir, for your presentation, and my friend Danjuma. As I joined the meeting, it was you who was making the comments. I just hear the last question that was asked by somebody from Ghana. In Zamfara State, we have what is called Emirate Health Committee. This Emirate Health Committee, they are responsible for sensitizing members of the public on routine immunization as well as other PSC services in their respective domains. So, and with regards to the COVID-19, it is impact on routine immunization and even its coverage in the state. Because of the strategies that Dr. Attahir mentioned in his presentation, in Zamfara State, we were able to achieve a remarkable success in which, despite being the state that is always considered to be backward, but because of these strategies that we are trying to implement, Zamfara State was managed to be the first state to achieve 100% coverage of its target. So this is that he mentioned the strategies of engaging the community, identifying, mapping out the stakeholders, the resource personnel in each domain, in each at each level. It is very impactful. So as it is now, even the second dose of the COVID-19 vaccination that we are doing, Zamfara State is also ranked in the second position in terms of reaching its target. So I think the most important aspect of routine immunization is community engagement and promotion of community ownership. So I will be here if anybody have more questions with regards to this. Me, Attahir, and even Enjuma, I will be able to answer some of your questions. Thank you very much.
Thank you, PM. Just to add on what he said, we have a health facility committee in our country, in all our facilities, who support mobilization and other things. Then in some facilities too, we have voluntary community mobilizers who also support immunization and other health scheme activities in our country. Though COVID-19 has, at the initial stage, has a negative impact on our routine immunization system because people are afraid to come out. Everybody is afraid to come out because there is lockdown, there is harassment by security personnel. So it's negatively affected vaccine uptake, but it didn't affect our this vaccine push distribution. At that period, we have a contractor who has been contracted to push vaccine to some Apex facilities, while we have like 147 Apex facilities in the state. So the other facilities come to Apex facilities to pick their vaccines. So it has a little bit reduces vaccine stock out. Maybe I've answered your question. Over.
Hello.
Yeah.
Hello.
Oh, hi, Adefoke. I was just about to ask you. Yeah, please feel free to ask your question.
Thank you so much. Well done. I must first of all join the other people congratulating Dr. Attahir on our wonderful presentation and exactly the stories, the narrative that he has given to everyone. By and large, I am one of the MST from National that always goes around for the supervision of the immunization. And some of my colleagues that visited Zamfara before also mentioned what most people had mentioned earlier, of which you said you're going to take care of it. But I want to suggest, based on your presentation, can we get more of these people, more of fathers, especially the male people, more involved in the real the exercise? When I say real exercise, as a some to be part of our mobilizers, some to be part of our recorders, so that if they themselves, they can speak with their friends. Apart from the fact that we have engaged the traditional, the religious people, then those people that will be working as an immunization team to go around, we can get more of male involved, so that when they speak with their counterpart father, it will also make it easier. Thank you. Since they have brothers and they have brother cousins among those people that will be receiving this antigen. Thank you.
Thank you, Dr. Adefunke. Really appreciate your comments. We practice something similar scenarios sometimes back, involving male partners in immunization. In not up north, there's what you call T-joint Meshai. Mostly male in the evening, around after 7, 8, you find male congregating around Meshai taking this. So we experiment using male to disperse information on immunization at that area and in such kind of gathering. So it works. So similarly, I think we buy your idea of involving male too as a recorders or vaccinators. Though we have a lot of them, but they are healthcare providers in our facilities. So some of them are not from the communities, but we are trying to we have a shortage manpower. Generally, what resources for health is generally short, but we are trying. The state government is trying to recruit. So in that process, during such kind of activity, we try to see that we push more men into that so that they can talk to their male colleagues. Thank you. Other questions, please?
Thank you very much.
Dr. Ira. Very proud of you.
Thank you.
This is PM speaking. In addition to what Dr. Attahir have said, we also have other ways of communicating with male regarding routine immunization. That is what is called a naming ceremony, in which after 7 days of delivery, a naming ceremony will take place. During that time, all the friends and the colleagues of the father of the newborn will be gathered to celebrate the naming ceremony. So during that time, there are people that are called town announcers. They are called, we call them town announcers. So we use them to pass the message of routine immunization. We also have some people that are resources available to pass the message, like the people we call barbers, the local barbers. They are the ones that are usually called to barb the hair of the newborn. So we told them, in fact, the plan is to use those people to, before they barb the newborn, they must ensure that he received his 0-dose antigen by asking the family to show him their immunization cards for receiving at least hepatitis 0 and OPV and BCG. So this is in addition to the answer that Dr. Attahir has. Thank you very much.
Great. Ismaila, I see that you put some questions in the chat. I was wondering if you wanted to come off mute and ask them to our presenters. Ismaila, can you hear me? I actually am also very interested in this presentation, and I have a question for you, Dr. Attahir, and also Almustpha. These sensitization sermons, I was wondering if you could provide some more details on maybe the training that was involved, some of the conversations you had to really create these sermons and disseminate some of this information on immunization to your communities.
Yeah, thank you. What the sensitization sermon, that we are trained on how to first of all, they were trained to understand what is childhood vaccination, because most of them doesn't know it. Then we add IPC skills into it, and we also add advocacy skills into this sensitization. So they have to find a way of understanding what is childhood vaccination, how are they going to pass that information to their followers. So most of the terms are in English, So you have to find a way of, okay, translating it to their knowledge level or understanding, so that when passing the information, their followers will not find it very difficult to comprehend. So I think those are the things we use this.
Great. Emmanuel, would you like to unmute and ask your question?
Yeah, good afternoon. It's actually, I'm happy for this presentation. It's actually timely, and Attahir and his PM SERICC have actually done so much in trying to explain. Now, but I still have one or two concerns. One, we've had a lot of even religious leaders, and when you sensitize a particular community, you still come back again, they are not yet sensitized. Or you have, based on denominations or based on religious sects, you sensitize this sect.
So we miss you, ma.
Are you hearing me?
Now
Okay.
we miss
Can you
you.
hear me?
Can you refresh? Can you come back, please? We miss you completely.
Okay, but can you hear me now?
Yes.
Yeah, loud and clear.
Hello, can you hear me?
Loud and clear.
Okay, fine. Oh, sorry. I said, you have a lot of religious sects, and then those sects sometimes, since they have their leaders, you sensitize a particular sect. The other sect tells you that, no, they are still not comfortable with the explanation of the other sect. Now, what are you doing to balance that? Because you keep sensitizing sect based on probably campaign. Every campaign you must come back because they are not fully convinced with explanations you are giving. We've had so many issues like that you must keep coming up at each round, explaining and seeking permission for them or the household heads to give their wards or children for them to be vaccinated. That's number one. Then another thing is that, what are you doing? Because they all look at polio has been the issue. So what is the SERICC or the Zamfara team doing, trying to segregate, because they look at it is polio that has started this issue. So what are they doing to leverage, or how are they trying to look at the people understand that vaccination is not allowed the polio, about other antigens that has issue of child barrenness, because they believe that when you give antigens or vaccines, it brings barrenness. So what are you doing about that? Thank you. That's just my contribution.
Okay, thank you, Ima. Let me start with your last question. We are leveraging on a lot of services so that we will leave immunization as an orphan. Currently now we have integrated immunization with all other services, family planning, ANC, malaria clinical treatment, and others. We integrate them, and nutrition. Then secondly, that this campaign that just concluded in 3 rounds, IMOP, Integrated Medical Outreach Program. During that IMOP, all services were conducted at the same time, which people came together, were able to immunize, treat other minor illness. If there is surgery, they refer to secondary health facility for surgery. So all those kinds of things that we are doing, we are trying to show people that polio has gone, but other immunizations still exist. Still, you need to bring your child for immunization so that you will throw the baby at the bathwater because you don't want polio. So we try to make people understand that. Then secondly, regarding the sex, when you enter a community, when you are doing your mapping, we look at who is the most acceptable leader, sect leader. If the sects are sharply divided, then we have to work with the 2 or 3 different sect leaders. But in some areas, you find some sects are margin. A sect, B are more friendly, more coherent together than sect C. So we merge sects A and B together, discuss with them, find a solution. We try to allow them to bring out their annoyance and vigilance on why are they doing this for immunization. Then we find a way of discussing with them, then softening their stand. Though at the beginning it's very difficult. At times, if you didn't calm yourself, fight will erupt. So you have to calm yourself, then gradually it works. So I think those are the two strategies we use. Thank you.
Okay. In addition, thank you very much, Dr. Attahir. In addition to his comment, I think in Zamfara State we have a strong advocacy tool, and that strong advocacy tool is the history of outbreaks of vaccine preventable disease in the state. Recently, about 2 years back, there was a catastrophic outbreak of Neisseria meningitis type A in the state, where more than hundreds of people died, lost their life. So when we go to any community, if they are hesitant to vaccinate their children against vaccine preventable diseases, we use that as an example. We ask them, when was the last time you see large-scale outbreak of meningitis in our state? Or when was the last time, how many people you saw with polio in your community? So if these vaccines are not working, then why are we not having meningitis like we used to have? Why are we not having measles like we used to have? So these vaccines, this is the advocacy tool that we use in trying to convince sectoral divides in order to convince them to accept vaccination services in the state. Thank you very much.
Great. Thank you so much, Attahir and Almustpha. We greatly appreciate your time and you presenting today. I am aware that we are reaching the top of the hour and the Boost team has some really exciting announcements and some next steps for today's attendees. So with that, I'll pass it to my colleague Liz, who will cover some of our exciting programming.
Great, thanks MJ. And thanks again to Attahir and Almustpha. It was an excellent presentation and a really wonderful Q&A. And just a reminder that they're also available on the Boost platform. So if you have additional questions, you can always reach out to Attahir there. So like MJ said, we have a few exciting announcements. So one is that we're introducing a new initiative called Sparks. So Sparks surface Boost community members real-time moments of innovation overcoming challenges. So in a similar vein as Bright Spots, but really surfacing things that are happening right now on the ground. We have a few Sparks that we published so far. And on the left, you'll see Martha, who's another active Boost member, who shared a little bit about her work around World Vaccination Week. So I definitely encourage you all to check out those Sparks, again, on our brightspots.boostcommunity.org microsite. There's more information about Sparks and how you can submit your own there on that platform. And of course, you can always reach out to us at info@boostcommunity.org if you have other questions. Next slide. So I know we're just at time, but just wanted to share out a few additional links. So as I mentioned, you can always join us on the Boost platform. We do have a learning group that is dedicated to our Bright Spot stories. So again, if you have additional questions, you can ask them there. We also have a Boost Telegram channel, which is a little bit new, but we've been using to share out announcements of events and other initiatives in the Boost community. So definitely would encourage you to sign up for that channel. And of course, to take our survey, just to give us feedback on this session. We really value your feedback and we try to improve future sessions accordingly. And as I mentioned before, definitely would encourage you all to share your Spark, your work with the community. I think that's all we have. Next slide. Yes, so with that, I want to thank everyone for your participation today. Again, special thanks to Attahir for sharing his work and story with the community. We really appreciate it.